which Stephen will talk about in more depth later on. So some of the skills needed for professional curiosity. So consider things like motivational interviewing techniques, open-ended questions, affirming what the person's saying to you, reflecting back what they've said and summarise to ensure that you share an understanding of what they're telling you, asking why and repeating, using open questioning techniques, who, what, where, when and why, using TED, so tell me, explain to me, describe to me, and sometimes show me. Is what you're being told out of sync with what you're seeing and how somebody's presenting? Assumptions, are you making any? Is there any bias at play? Being comfortable with silence, giving people thinking time and time to elaborate. And your subjective observations, so consider the tone of voice and body language. Is the tone and body language reflecting what the person's saying to you? Barriers to professional curiosity, things like being in a rush. So if you're in between visits and you're running late, or you know that you need to get somewhere else, that can have an impact on your ability to explore with people. Professional deference, so accepting a superior's judgment over your own or feeling unable to challenge that, which is especially important in capacity decisions. Normalisation of situations. Confirmation bias, using new information to confirm preconceived ideas or confirming what you're expecting. Knowing but not knowing, so using your gut feelings as a form of information. Vague or conflicting records, that it's really important that we challenge this and challenge if information is too vague and make sure we get more information. And confidence or a lack of confidence can also be a barrier. So why is it important? So a lack of professional curiosity can lead to missed opportunities to identify the less obvious indicators of abuse or vulnerabilities. Assumptions made in assessments of people's needs or risks which aren't correct can lead to the wrong intervention for people or families. Presenting issues can be dealt with in isolation if you're not looking at the whole picture, and a high reliance on self-reporting by parents or carers brings the risk of proceeding with an intervention based on false information. So is exercising professional curiosity easy and straightforward? Not always. Oh, sorry. Over to Sam.
Thank you, Colette. So, case study that I'm just going to talk about is Mr. and Mrs. Smith. So, as you can see, Mrs. Smith has a diagnosis of advanced dementia. Mr. Smith was her carer. We in the safeguarding team received a referral from a community occupational therapist suggesting that Mr. Smith was coercive and controlling and not accepting professional advice. The GP practice nurses also raised concerns that Mr. Smith was not following medical advice. The overall outcome was it wasn't safeguarding, thankfully, but how did we get to this point? So regarding professional curiosity, nobody asked why. So the occupational therapist only visited Mr. Smith once and explained the equipment to him when it arrived. On their review visit, they didn't ask him why he was not using equipment, nor did they show him again. When I asked him, he said it was too difficult for him due to the flooring. Obviously, the occupational therapist was younger, fitter, able to move it. He wasn't. He also couldn't remember exactly how to use it. He'd only been shown once. And no one actually had asked him why he wasn't using it. They came in, saw he wasn't using it, and just made a safeguarding referral. When Mrs. Smith was going to the doctor's surgery, the practice nurses wanted to take a urine sample from her because they believed she may have an infection, because the symptoms that Mr. Smith had described meant that she changed. So Mr. Smith said they asked him if they could take a urine sample from Mrs. Smith. He said no, and they just accepted this. I asked Mr. Smith why he declined on his wife's part. He said because they didn't tell him what it was for. They didn't ask him why they needed a urine sample. They didn't explain to him what they wanted to do with that. But also they didn't check out whether Mrs. Smith had capacity to make that decision herself. They didn't ask her those questions. They asked him straight away. They took his word for it, and they let him make that decision on her behalf. But also the worrying thing was, if Mr. Smith was being abusive, this would have been a key time to have those conversations. They could have taken her into a toilet out of the way. They could have asked her how she was doing. And yes, she did have dementia, but she might have been there might have been bruises they could have seen. There could have been a way she talked about him, but they just didn't ask those questions. The occupational therapist also stated that Mrs. Smith needed care, as Mr. Smith could not use the equipment, and this was putting Mrs. Smith at risk. And they also stated that Mrs. Smith was unsafe without care in her own home. Again, however, they didn't ask Mr. Smith why he didn't want care. His exact words to me is, "I don't want people in my house all day and night." And when I asked him why he didn't want carers in, again, with all day and night, he said, "When I married my wife, I married her in sickness and in health. He felt a legal obligation to support his wife and be her carer and look after her because of his wedding vows." And from my perspective, from a safeguarding perspective, if other professionals involved took the time to explain to him and ask him why, we may not even to have got involved with Mr. and Mrs. Smith. They didn't ask him why he didn't want to use equipment, or why he wasn't using it, why he wouldn't let nurses take a urine sample, and they took his word on face value. And of course, if there was domestic abuse occurring in the house, or he was coercive and controlling, no one actually spoke to her in private, so they wouldn't have even been able to build up that picture. So it could have been a very different outcome. And unfortunately, this is what we see in the domestic homicide reviews and the safeguarding adult reviews, which Stephen will talk about next. So again, some top tips. Look to see what's going on. Okay. Look to see what's going on. Listen to not what you're being told, but also ask those questions, ask those difficult questions, ask the why question. It's a really important question in professional curiosity. Check out what someone's saying. So now I'm going to hand you over to Stephen.
Thanks, Sam. So I'm going to be talking a little bit about learning that has been identified from Safeguarding Adult Reviews, or SARS for short, in relation to professional curiosity. And that's going to be locally and from a national analysis of 231 Safeguarding Adult Reviews for 2017 to 2019 that was published last year, and that covers a much broader range of learning. The national report is a very detailed document covering 245 pages, and there's a lot of learning about all areas of adult safeguarding. And while I've extracted key points, it's a very detailed document. And if you haven't had a chance to read it yet, we've put a link at the end of the presentation that will circulate to everyone after the webinar. Due to the way the mandate for SARS is phrased in the CARE Act, they're inevitably going to be focused on learning about what's gone wrong, but I've also tried to pick up examples of good practice too, that I'll highlight as we go through. So I thought it would be helpful to begin by briefly covering the criteria for a mandatory Safeguarding Adults review, which I've put on the slide. And SARS were introduced in the CARE Act in 2014 and replaced serious case reviews. It's really important to emphasise that the adult doesn't need to have been in receipt of care and support services for a Safeguarding Adult review to be considered. And Safeguarding Adult boards are also free to arrange for a discretionary SAR in any other situations involving an adult in its area with needs for care and support as well. So in terms of local learning, in our Luke SAR that was published in 2020, many of the early concerns about his behaviour were dismissed as a lifestyle choice, and there was a lack of exploration as to why he was behaving in the way he was. In another unpublished SAR, a no news is good news approach was taken when a long-standing pattern of contact with professionals and services changed suddenly, and there was no attempt to find out what had happened. Other issues that have been highlighted in the work we've done locally include the acceptance of statements on face value. For example, that someone can do something because they've said they can without checking out if that's correct. And this doesn't have to be done confrontationally, as colleagues will talk about later on. But where professionals are worried about something, they should try and find a way to explore it. There was also a lack of triangulation between professionals. So, for example, if you have concerns, talk to colleagues that you know are also working with the individual to see if they are seeing the same things that you are. Other areas highlighted include where capacity assessments for one decision might have been used to assume capacity for all decisions, or assuming that the person has capacity without doing anything to explore concerns that you might have. And there was also a regional analysis that took place 2 or 3 years ago that we contributed to, and that also found that in some cases the right to autonomy had been promoted over the right to life and freedom from degrading treatment, and that making safeguarding personal approaches had been misused as a reason for non-intervention. So moving on to national learning from the national SAR analysis. As I said earlier on, this is a really substantial review. It's the first national review of SARS since the implementation of the CARE Act, and included both published and published reviews, and it builds on previous studies undertaken with individual regions, including in the Southwest. And it includes 3 SARs that were completed here in Somerset within the time frame it looked at. The first one was SAR Damien, which was an unpublished review at the time, and that SAR has been revisited and a new report was published on the 31st of March last year. It included the Tom SAR and the SAR for Mendip House as well, but all 3 of which are now on our website. In the analysis, professional curiosity was highlighted as an important skill in gaining an understanding of the individual, recognising the significance of their history and recognising the significance of their history. For example, childhood trauma, loss, bereavement. In cases where professional curiosity had been used, the analysis references comments in SARS such as agencies understood the adult's losses, frustrations, anger and hopelessness. They knew of the adult's history of a childhood mainly spent in care with little stability. On one occasion, a SAR enabled practitioners to secure agreement to provide access, and quoting it, the analysis says that the professional curiosity and resilience demonstrated by the officers attending resulted in the officers gaining access to the property, having tried persistently for over an hour. So it's not just about learning where things didn't happen, it's about learning where good things happen through people using professional curiosity to help them work with an individual. Along with the reviews considered nationally, among the reviews considered nationally, there were examples where SARS focused on where people were placed in services, and learning for how reviews should be carried out included that learning that came out of our Mendip House SAR here in Somerset. And some of that learning from that safeguarding adult review included that reviews of care should be part of the overall monitoring and safeguarding process, which goes towards checking people are receiving good quality, safe services. That for people with complex needs and histories, a review should be a process rather than a one-off meeting sitting in a manager's office. And that if services attempt to get you to conduct a review in this way, you should make your expectations clear that you want to see the person in an environment that's comfortable for them. The aim should be to gather and consider all relevant information needed for that particular moment, and reviews should be proportionate. And for some people's circumstances, particularly where they are having difficulty advocating for themselves or lack capacity, this might require more inquiry and consultation with others who know them well. A face-to-face visit with the person you're reviewing is an essential requirement of a review process. And even if you have to do more than one visit to enable this to happen. If you arrive to find that you're not able to meet the person or able to arrange to visit them again, establishing a clear expectation that you wish to see them with the care provider is a really helpful way to take things forward. And it's always good to remember that families are often an underused resource and are really good sources of information. They know their son or daughter, mother or father best, and may have the most contact with the service that they've been placed in. And sometimes we've seen that across both local and national SARS that families have had concerns but have not formulated them or spoken with anyone outside the service provider. So it's good practice to offer families a chance to speak to you privately, in person or via a phone call. And it's also a good approach to try to foster positive, though objective, relationships with staff, as they can be good sources of information and may want someone to talk to if they have concerns. And a review visit by an inquiry professional can sometimes trigger a staff member to whistleblow or raise concerns in a different way about something they're worried about. And when visiting services that describe themselves as specialised, professionals need to ensure that they gain evidence that care is effective, high quality and evidence-based, and don't assume that everything is all right without seeing the evidence for it. It's a big piece of learning from a number of SARS now nationally is not to assume that a service is providing specialist care because of the way it describes itself. And overall, the emphasis should always be on assuring yourself that the care is good and that the environment is safe by considering all the evidence, not just believing what you're told or reviewing written information only. Professionals should never accept explanations that attribute concerns that they've identified to a person's behaviour on face value. So another area of learning in the national analysis was around self-neglect, and the analysis suggests that disproportionately in relation to other types of concern, self-neglect is not being identified as a safeguarding concern until it has reached a stage where the criteria for a safeguarding adults review has been met in far too many cases. The analysis noted that self-neglect, both in itself and as a form of abuse and neglect within safeguarding, was not always recognised by practitioners. It noted that one SAR in the sample found no evidence of self-neglect or safeguarding understanding embedded in primary care, mental health services or commissioned health and social care provider staff, and that the focus on a specific need or behaviour could obscure recognition within the SAR. The SAR, quoting a SAR that was looked at from the analysis, it states that self-neglect was not recognised or named. The adult was assessed in hospital for detox. In this assessment, practitioners are not looking for self-neglect. They are assessing alcohol misuse problems and risk assessing for immediate self-harm, which may lead to a mental health assessment, which suggests a different lens than would be used to identify if someone was self-neglecting. This raises interesting questions regarding how self-neglect is identified. The analysis also notes that even when self-neglect was recognised, it was little understood and poorly explored, lacking detailed personal history and exploration of the person's home conditions or health management routines. It comments that refusal of services was often not explored or understood. Professional curiosity was not exercised around things like where assessment took place in a hospital context, and that relied really heavily on self-reporting by an adult, with home circumstances not observed, so no check around whether someone could do what they said they could do, for example. In some cases, assurances about actions the individual would take were accepted at face value despite evidence to the contrary, and it also found that poor recognition of risk meant that sometimes professionals were simply not worried enough to take action. In relation to an adult's capacity, the analysis quotes another SAR which states that there were consistent misunderstandings related to self-neglect and mental capacity. Agencies were aware that the adult was self-neglecting, however, they also assumed that the adult had mental capacity and consequently, and erroneously, decided that an intervention was not possible. Such an inflexible approach to managing adults who are self-neglecting with alleged capacity runs counter to the Care Act guidance that suggests individuals who are no longer able to protect themselves are still owed a duty of care. In one other case looked at by analysis, the individual was assessed as having no eligible needs despite being unable to maintain a habitable home. In another, assessment did not lead to action, and in a final case that is referenced in the analysis, practitioners made assumptions that their self-neglect was a personal lifestyle choice, despite the concerns raised by family and friends in relation to deterioration and presenting risk factors. So the final area of national learning from the national analysis I'm going to cover is around supervision. And in some cases, just as professional curiosity was absent, the analysis found that so too was supervisory curiosity, with a lack of challenge and a failure to consider patterns of thinking such as cognitive or confirmation bias, leading to misinterpretations of circumstances going unnoticed. One SAR commented that materials to support reflective supervision in adult safeguarding were limited. In some circumstances, staff had not been supported to manage the personal experience of their work. In one case, staff were described as traumatised, in another that they struggled to deal with the emotional impact of 2 deaths. In a further case of severe hoarding, risks to staff had not been assessed or met, including the need for protective equipment. And in another SAR, it was found that insufficient attention had been paid to the well-being of practitioners, and there was a lack of recognition of the emotional impact of the work on staff. I'm now going to hand over to Louise, who's going to start talking to you about the techniques that can be used around professional curiosity.
Thank you, Stephen. So my name's Louise, and I wanted to tell you a short story about why I feel it's important to offer up some practical tips for having a professionally curious conversation. I'm a mental health nurse, and 40 years ago I was a very shy, naive young student nurse working on my first psychiatric ward. It was my first week and I was told to go and sit in the lounge and talk to the patients. So I nervously sat down next to an older lady who I knew was blind and she looked depressed. And I wondered how to start a conversation with her. I thought about asking, "How are you?" But I told myself no, because it was obvious she wasn't okay. She was in a psychiatric hospital. Then I thought about asking her if she was married. But again, I told myself no, because I was worried she might tell me she was recently widowed and that's why she was depressed, and I didn't want to upset her. So I just sat there in silence, not knowing what to say, but feeling really awkward. And after 40 years, whenever I think about this experience, I'm back in that moment feeling anxious and useless. And it's that lady and my sense of impotence that drives me to try and simplify what can, on the face of it, seem and feel like tricky conversations. I would have loved somebody to give me some simple tips for starting conversations in this situation. So this section of the webinar is aimed at everybody, regardless of knowledge, qualifications or experience. It can be difficult for anybody to start a conversation that might be uncomfortable. Like my earlier experience, we might worry about upsetting the person or making them angry, or we might worry about what to do with the information when we have it. And this hinders professional curiosity and can lead to us avoid starting the conversation at all. And that's what it is. It's a conversation. It's not an inquisition. We can learn from children and animals. Think about watching a toddler encountering something new. Once they've got over any initial apprehension, what do they start doing? What might you notice? And I'd really appreciate it if you could just put some of your thoughts into the chat. Firstly, they start from a position of not knowing, and they're not embarrassed about not knowing. They explore using all of their senses. Babies put things in their mouths. Cats and dogs smell things around them, their ears alert to noises. They pause when there's something unexpected before exploring more, and we need to do the same. And children persistently ask questions, and they keep asking until they're satisfied. Then they reach their conclusions. What they might then do is change their view when more information comes to light. So think about Father Christmas. The young child decided Father Christmas is real because everybody told them he's real, and all the clues pointed in that direction. As time passes, they receive extra information and clues, which make them question their original conclusion. So then they reach a different view. In our work with people, we need to be open to changing our original view as more information comes to light. So the next slide will give you some very limited information about a scenario. We'd like you to read this and think about what might you want to know about next. We all come from different areas and fields of work. So to make use of all of the knowledge, experience and wisdom in the room, and for everybody's benefit, please again put your thoughts in the chat. You might have ideas that other people didn't think of. And this is one of the values of multi-agency working. It highlights the valuable contribution everybody can make, and it isn't limited to qualified professionals. Other people with a connection to the individual often have a different relationship and can offer a unique perspective. For example, community agents, faith partners, volunteers, just to name a few. Relationships are at the heart of our own daily lives, and it's no different when we're at work. We all need time to build relationships and trust, and we all expect to be treated with respect and good manners. When we meet new people in life, we get to know them over a period of time. We learn to trust them more as the relationship develops, and we share more intimate information about ourselves and our struggles as the relationship develops. Being a professional doesn't give us an automatic right to be trusted, and in some respects we need to work even harder. And people may have very good reason to be suspicious of our motives and intentions. So it really helps to acknowledge that from the outset and be clear about why we've arrived in their life. Some people can feel intimidated or want to please professionals by giving the right answer. And you must avoid believing you know this person's situation because you've read the case records. You are the novice in this situation. The person is the expert, but you are seeking to become knowledgeable. And to highlight this point, we would urge people to read an article about Elsie's story, and a quick Google will find it. It's called Self-Neglect and Somebody to Safeguard, Elsie's story. Seek consent to explore the situation. You might wish to try the statement or the question on the slide. So, may I ask you some questions? Or I might need to ask you some personal questions to really understand what's been happening for you. But then you must listen. Nobody carries on talking if they think the other person is not listening, not interested, or making judgments about them. It's tempting to be thinking about your next question while the person is talking, but they can tell you're distracted and not listening. Active listening is not just about what we hear or the conversations we have. It's about using your whole self to listen, all of your senses to take in the situation. So I'm going to hand over to my colleague Jo just to develop this part of the webinar a little bit further.
Thanks, Louise. So essentially what we're talking about is building on communication skills, and we've all been developing communication skills for a number of years, and that will really help aid professional curiosity and support us to have these conversations. So in order to open up conversations with individuals or family so that we can use the 5W questions that Colette mentioned earlier, we could also try using the TEDS model, which is tell me, explain to me, describe to me, show me. Now, one of the benefits of this model is that it helps us to draw out the person's or the family's own lived experiences and their views of the situations in their own words. It's really important for us as professionals to use the person's own word, and that's especially important in relation to record keeping, because that will help to keep that person in sight or that family and their voice heard even when they're not present. It also helps to maintain it's their view rather than the professional's interpretation of their response, and that in turn will help reduce the likelihood of our own values or beliefs impacting on what we've heard. So at each stage, when we've been offered some general information, we can then start to use your 5Ws. So for example, tell me about your daily routine, or tell me what's the first thing you think about in the morning or the last thing you think about at night. So that gives you some starting information and helps us to get to understand the individual's day or the things that might be worrying them. And you can then start to use your 5Ws to clarify more. So when does that happen? Who does that? Why do you think he or she does that? And what effect or impact does that have on you? Another example could be, tell me, how do you or your family deal with stress or conflict? Describe to me, what's it like to live here? And explain to me, how does it make you feel? What does it make you think about? And although we've spoken a bit about asking those open questions, and that helps to create that greater dialogue, we also need to be mindful that there are other times when it's helpful and necessary to ask those closed questions and then dig a little deeper, such as, do you feel safe? Have you eaten today? And that might naturally lead on to the more of the who, what, why, when, or explain to me, describe to me, or show me questions to help gain that narrative information, such as, do you feel safe? Who or what makes you feel safe? Who or what doesn't make you feel safe? What have you eaten today? All of these will help gain a bigger picture. Following on from what Louise had said about developing relationships and building trust with individuals, it's really important that we all keep asking. So as we develop relationships, the individual or the family might feel more inclined to share their true feelings or thoughts with you, but they might not feel quite confident enough to bring them up themselves. So therefore, if we keep ensuring that we're asking the same questions, and that's especially important in relation to safety or risk that we're worried about, and that we record and act on those responses, it gives them the opportunity to open up. Next, we're going to look at some examples on how we might have responded to the earlier scenario that Louise had spoken about. Thank you to everyone for putting their comments in the chat. That's some really useful starting points. So within this, we're just opening up a dialogue in relation to that scenario. So, for example, the ambulance crew, they were worried that your house felt cold. Could you tell me a bit more about that? What sort of heating do you have? When do you have the heating on? Why don't you have the heating on? Can you show me how the heating works? And I know that people had mentioned that in the chat bar about the heating and the bathroom. Can they access the bathroom? Do they know? Can they get to the bathroom? So they're all really helpful things to begin to break down the situation to understand a bit more. So it might reveal a number of things, the answers to these questions, that they might not know how to use the heater, or the heater doesn't work, or that they're worried about money and they can't afford to heat their home. But we need to start exploring like the young child that we thought of earlier. Start asking those questions like a young, curious child would. But most importantly, as Louise has mentioned already, we need to be open to new or emerging information that might alter our first impressions. Next, we'll talk briefly about the show part of the TEDS model. So we all know that just because we say we can do something doesn't mean we can or want to actually do something. So I could tell you I could abseil down a cliff, but could I really do it? Would I really want to do it? So people can tell us what they would do. So for example, if I was thirsty, I'd make myself a cup of tea. But doing that involves lots of different steps. Buying the things that we need, making sure I have a cup, the milk, a kettle, doing all the things in the right order, and being safe using boiling water. So a simple reply to what would you do if you were thirsty, if taken at face value, could feel really quite reassuring. But we need to consider if that person's got a history of becoming unwell through dehydration, for example, or someone's concerned about self-neglect or implying that a person is making unwise decisions or lifestyle choices, this might hint that although they know what to do, they don't or necessarily can't do it. And it's really important that we check that out to be sure. So of course, it could be for a number of reasons why somebody can't or won't do something, but one of those reasons might be executive dysfunction, being able to talk the talk but not walk the walk. So here you might use those show me questions. Can you show me how you do that? Can you show me where that is? Can you show me how that works? And using those show me questions, as well as the other questions covered in the TEDS models and the 5 Ws, will help us to understand more about the person's experiences or abilities from their own perspective. And using all of these professional curious questions aids us to gather a lot more information, and that information can be clarified with other people, especially if still needed. So let's ask the person, who else is involved? Who's your support network personally, professionally? And seek to find out if others are being told the same as you. Is their experience the same as yours, or is there any incongruence that needs addressing to be brought out in the open? Thinking the unthinkable allows us to seek to find supporting information that the unthinkable is not occurring, and that inevitably will aid and support professional curiosity. We also need to consider we all have different systems. What systems do we have in relation to information sharing? Where can we seek this information? We need to clarify, is anybody else concerned? What support has been given so far, and is further support needed? MDT meetings will support this, especially when they're thoroughly recorded and with clear actions and timeframes. All of this will help support professional curiosity and promote safer cultures and safeguarding through that improved joint working and information sharing. And of course, even when we have all this, have asked all the right questions and we have all this extra information, we still might feel unsure. And this is where the reflective practice and regular supervision will support. And since COVID, one of the real downfalls to remote working is that we miss those opportunities in the office when we've had a difficult call or a visit to discuss or potentially see from a different point of view or gain that different perspective. So what do we do about that? Well, we need to actively seek the support to help us, need to make that Teams call to a colleague, discuss cases in supervision, have a brief touch base with a colleague at the end of the day, and all of that will help to promote curiosity. And it'd be really interesting to hear from anybody on the call if any organisations, how they encourage reflective practice or any trigger charts for supervision since COVID. We pop in any ideas into the chat bar for everybody to see. That would be really helpful. Next, we just have a couple of example slides on different questions that we might that might prompt us to act in professional curious ways. I'm not going to go through the questions, but there are a number of them here, and some of the people have already put them in the chat bar from the earlier scenarios. So, but if anyone's got any more example questions that they could add to the chat bar just for us here, that would be really helpful. So that's it from me. I'll hand back to Stephen now to conclude. Thank you.
Just to conclude, thank you to everyone for joining us today. I'm just going to conclude with a summary of some of the top tips to taking forward professional curiosity in your day-to-day practice. So one of the some of the top tips that we've come across in what we've been looking at in order to put today's webinar today are to question your own assumptions about how individuals, families function, and to watch out for over optimism recognise your own feelings, for example, tiredness, feeling rushed or feeling poorly, and how this might impact on your view of a child, adult or family on a given day. Think about why someone might not be telling you everything and why we need to find out why a situation has come about. Demonstrate a willingness to have challenging conversations. Address any professional anxiety about hostile or resistant individuals or families and how they might react to being asked direct or difficult questions by planning your conversation and trying to work out the best way to start those conversations, as Joe and Louise have been through. Remain open-minded and expect the unexpected. Think the unthinkable so that you can rule out and provide supporting information as to why our judgment is that the unthinkable is or is not happening. Appreciate that respectful skepticism, nosiness and challenge are healthy. No matter how difficult it can sometimes be, it is good practice and okay to question what you've been told. And recognise when individuals repeatedly do not do what they said they would do, and discuss this with them. It's good practice to understand the cumulative impact of multiple or combined risk factors. For example, domestic abuse, drug and alcohol misuse, mental health, illness, and to ensure that your practice is reflective and that you do have access to really good quality supervision. Alongside this webinar, we've also today published a new 7-minute briefing on professional curiosity that you can access on your website and that I've just added to the chat. And we've also added a number of resources to the end of this presentation, which I'll send out after the webinar's finished, and that includes links to all the resources that the Somerset Safeguarding Adult Board has published, along with national resources, including the national analysis I've referred to, and resources from the NHS Trust, as well as from other safeguarding adult boards, and a couple of resources that were primarily aimed at children, but where similar concepts to what we've been talking about today would apply. So thank you for joining our webinar today, and to colleagues from NHS Somerset CCG, Somerset NHS Foundation Trust, Yeovil Hospital NHS Foundation Trust, and Somerset County Council for all their work on producing and presenting it. So does anyone have any questions? You're welcome to come on camera or just put them in the chat. And the final thing from me before we get to questions is we're really keen to develop more learning and perhaps run more webinars. So if you could complete the post-webinar questionnaire that I'm just about to post in the chat, and we'll send a link out to by email after the webinar, we'd be really grateful to help us take this forward.
Hello.
Hello.
Hi, thank you. That was really good. Yeah, it's interesting. I think you raised some really interesting points, and I think the TED's things are really practical kind of, thing to kind of start off with, which I think is really, really useful. And it's good just to kind of remind yourself sometimes, isn't it, that actually sometimes simple, kind of go back to the beginning, simpler approaches can be hugely beneficial. But I guess this isn't so much of a question, because I'm from the Huntington's Disease Association, and self-neglect features frequently and is obviously extremely challenging. And as you mentioned, it features a lot in the SARS, doesn't it, but not necessarily so much in initial inquiries, which I think is very interesting, although of course worrying. And I know I haven't done much research into self-neglect recently, but I know that it's kind of guidance around self-neglect and how and kind of what to do it when you're at certain stages, I think is perhaps lacking or not always clear, isn't it? And I think I guess it's if professionals find themselves in a situation where they think, right, we've got self-neglect here, and I'm especially thinking of people that I work with where there's issues around cognition, as you say, and executive function and things, and how they may be able to say certain things and appear that they understand, but actually they may not kind of be able to follow that through or put things in place to safeguard themselves. So I guess I'm just thinking kind of more clear guidance around self-neglect would be really good, so that when people are in a rush and kind of going, I'm really worried about this person, but what can I do? Have I done X, Y, and Z? Would be great. Are you aware of any such thing or anything like that? Do you have resources around that?
We, in addition to the guidance we've got around professional curiosity, we've published guidance on our website. And that links in the resources that are at the end of the presentation.
Okay, great. That's great.
But in general, I think it's an area that's been highlighted nationally for learning. And as we go into our next strategic plan for 2022-3 onwards, it has been highlighted as an area to look at across the local system around improving the way we work with people who are self-neglecting. I don't know whether colleagues have got anything else to add.
I was just going to echo that, Stephen, and just say that the problem with self-neglect, it tends to get to an extreme point before people get involved, and actually prevention to those points is going to be really helpful. So one of the areas that Stephen mentioned that looking developing is what to do if it's not reached safeguarding yet, but how to prevent it from getting to that point, and what avenues can professionals explore and link in with before it gets to that area. But there is some reading around executive dysfunction in relation to capacity, in relation to the Capacity Act, and people's ability to walk the walk and talk the talk, available in I think it's 39 Essex chambers, and there's some practice guidance in that which might support those areas. But certainly, as we develop that area, like within the SARB, we're referenced to those particular resources. But that just sprung to mind when you were asking those questions, because I think that's probably the area within Huntington's that you're talking about, someone's ability to execute and complete the task that they say they can, even if they can talk you through step by step. So, I'll see if I can find the link, and then perhaps when we send out the exit survey on via email, I can ask Stephen to add it in, if that's okay, Stephen.
Yeah, of course, Jo.
Yeah,
that would be great. Thank you.
I've also put the link in for you in the chat to the Somerset Safeguarding
yes.
Adults Board self-neglect practice. Okay.
Thank you very much. That's great.
Thank you. I can't see any other questions in the chat, and if unless
the only questions, Stephen, are just about, are we going to send out the slides? But I have answered that. But if you could give everyone an answer as well, that'd be great.
So I'll send out the slides straight after the webinar. I've recorded the webinar, but it will take a little while to download, so it probably won't be sent around to everyone until midweek next week, by the time I've downloaded it and processed it and uploaded it to YouTube. So I will send a link round when it's available though, and please feel free to share it with your colleagues. So I can't see any other questions, and I can't see any hands up. So if nobody else wants to ask any questions, we'll draw things to a close. So thank you all for your time today, and again thank you to colleagues for all their time today and in helping pull it together over the last couple of weeks.
Thank you very much. Thanks.
Thanks a lot.
Thanks all for coming.
Thanks. Bye.
Bye.